Good evening and welcome to Doctors on Call. I'm Dr. Paula Termuhlen, Regional Campus Dean at the University of Minnesota Medical School, Duluth Campus. I'll be your host for our program tonight on cancer, diagnosis, treatment, and survivorship. The success of this program depends on our viewers, so please call in with your questions on cancer and we will do our best to answer them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Jeffrey Copeman, a family medicine physician with the Fairview Mesaba Clinic in Hibbing, Dr. Lloyd Ketchum, an oncologist with Essentia Health, and Dr. Sandy Stover, a family medicine physician and faculty member at the Medical School Duluth. Our medical students answering phones tonight are Ryan Emanuelson of Owatonna, Minnesota, Tyler Floden from New Prague, Minnesota, and Jennifer Tomala of Big Lake, Minnesota. And now, on to tonight's program on cancer, diagnosis, treatment, and survivorship. So Dr. Copeman, I have a question for you. One of the things, the best news that we can say right now around cancer is that we have so many survivors. People are living with cancer today. What kind of information do you think is important for someone to share with you about perhaps their treatment or other things that they might have experienced during cancer so that you can take the best care of your patient across the spectrum?
I think the most important thing is that once people have been treated for cancer is that we have a regimen of ongoing follow-up, and that includes not only with your primary care physician but also with oncology. The other thing that we see sometimes is that people tend to forget that if they are a survivor of one type of cancer, we forget about screening for other kinds that are the standard of care, and so it's really important to do that.
Very good. And Dr. Stover, how about you?
Well, I absolutely agree, but I also think it's good to come back to the basics. We know that for cancer, if you are taking care of diet, if you're doing regular exercise, you reduce your risk for many kinds of cancer and improve your ability to stay healthy through the treatment that you might need. And so continuing to help support patients with that healthy lifestyle is part of providing good overall care. Immunizations too, to make sure that people stay fully immunized can help reduce the risk for some of the other things that can make it harder for the body, the immune system, to take care of itself.
Yeah, and so Dr. Ketchum, as you're transferring that care of the patient from their active cancer treatment to now to survivorship and surveillance, what kinds of things do you think are important for that patient to share with their primary care doc? Or perhaps what you think you would like to share with them?
I think it's important for them to let their primary care doctors know what they've been through so they can understand what kinds of treatments they have. We try to put together a packet of information for them so that they have a packet of information of exactly what they had, so they can take that to their primary care. And it's particularly important when people change where they're living. Sometimes we'll take care of somebody and they move, and then they're new. It can be hard for them to find that. So I think that information is all very helpful.
Good. Well, I think another area that we might spend a little bit of time on are the patient that's diagnosed perhaps as a child with cancer or maybe as a young adult, and they survive that episode because, again, childhood cancer survivorship has really increased substantially. And thinking about for the long haul, what kinds of things should they be aware of?
I think it's important to remember that when a child has the strong medications that are needed to treat cancer, that those also tend to impact growth and development. And so that can be an issue for how their teenage years go, but it's also a little higher risk and for a lot of the medications that are used for developing secondary kinds of cancers later on. And I think maybe that you could speak more to that about the radiation versus chemotherapy. Do you feel one's?
Yeah, I think that's a very important issue, especially for the children, because they tend to not stay in the same place, and so they tend to move a lot of times, and they change their healthcare system often, and they're at higher risk for a lot of different kinds of cancers. And we actually do screening a little differently for them. And so I think it's important for their primary doctors to understand what they had done so that they can do the appropriate screening for them as they grow.
You know, I know one area, so as it turns out, I take care of cancer patients as well as a cancer surgeon, and particularly in our breast cancer population, women who may have had radiation to the head and neck region because of a lymphoma diagnosis actually remain at very high risk for developing breast cancer over the course of their lifetime. So we have them in a special screening program. Includes MRI, mammogram, and usually being involved with someone who is knowledgeable about that, making sure that they don't have, that we catch anything early. So speaking of catching things early, since diagnosis is one of those things here tonight, I think one of the things that confuses patients across the spectrum is what are some of the latest recommendations around screening, and you alluded to that, Dr. Copeman, about that patient who's made it through one episode, and let's not forget about the other things.
Yes.
So I'm going to ask about a specific one, which has to do with colon cancer, because there's a whole variety of ways we can actually screen now for colon cancer. So what is it that you like to do for those patients, and just a little bit about maybe when you do it?
Dr. Ketchum and I were talking a little bit about this before the show, and my opinion is I still think that the colonoscopy is probably the best test. And the reason for that is the other two that are available, the FIT test, which is FIT, and the Cologuard, is that there really is no treatment involved in that. It basically is a screening, whereas when you have a colonoscopy, if you have polyps, they are taken out and they're looked at underneath the microscope, and you can develop and look at what kind of risk of cancer from that. So I always try to encourage my patients to have a colonoscopy. There's certain populations that were, just that particular procedure is something that they don't want to do. Then we have what's called the FIT testing, which is done yearly, and every 3 years we'll do the Cologuard.
Okay. And so along those lines, one of the things that we talk a little bit about for patients who may have had a diagnosis of cancer, particularly colon cancer, and they know that somebody in their family had it at a relatively young age, that's important information.
That's huge, yes, because like with other cancers, that we start screening differently, especially with first-degree relatives that may have had a colon cancer.
And as I understand it, it's typically about 10 years younger. You start 10 years younger than the youngest person who had it.
Yes.
Yeah, and I think that's something for when, especially around the holidays when people get together to talk with their families, just making sure that people are aware of things. So Dr. Stover, another question that I have for you is, are you getting asked questions about genetic testing?
I have been asked about genetic testing, and that's what's been an explosion of available options over the last few years. And I think it's important to rely on good advice for the kind of genetic testing that will best meet the needs of an individual. I know some people are looking at 23andMe and some of those kind of tests, which are not really in a good place for helping people make decisions about their own health care. They're interesting, and it's a fun thing to do, but going to your physician and looking at what your risks are can help refine the kind of tests that you want to do. They've become less expensive. Insurance companies are a partner in helping figure out the best test for what it is that you want to get out of that testing.
Yep, fair enough. Well, speaking of testing, we have a question from a caller from Duluth. So Dr. Ketchum, I'm going to throw this one at you. Are PSA tests accurate for prostate cancer screening? And so maybe just even explaining what the PSA test is and maybe what current state of affairs might be.
The PSA testing's been something has been sort of challenging. It's a good screening test. It does identify prostate cancers earlier. There have been some studies that suggest that, unfortunately, we may actually do some harm by doing PSA screening if we're not doing it in the right patient population. And so I think it's a conversation that people need to have with their primary care doctors about whether that's the right thing for them or not. And then if the PSA is abnormal, we always follow that up with seeing a urologist and biopsying it.
Fair enough. I mean,
what I might throw in there too is that a lot of times patients will come in and they will just want to have a PSA and not the digital rectal exam. And actually diagnosing prostate cancer is better with the combination of the two, because you can have a prostate cancer that may not make the PSA go up. And we may find a nodule, and that's something that should be taken care of. The other caveat that I have to that is that what to do with an abnormal PSA. And that's where there's a lot of questions that are out there. If it's mildly abnormal, does that mean I have prostate cancer? Is there other things that can make a PSA elevated? There is. And so it's really important that when you have that you discuss that with your doctor as to what the recommended next step is.
Well, so we have another caller, and this is a gentleman from Cloquet who'd like to know what type of exercises reduce the risk of cancer.
Well,
Dr. Stover.
And it isn't necessarily a specific kind of exercise, although it definitely aerobic exercise is in the best interest of 150 minutes a week is a good recommendation for overall health. I think it's a combination too of looking at what you're eating, because overall excessive body weight can be a risk for some cancers, particularly breast cancer. But I think it's also really helpful to think about what does exercise do for psychological health, and that's a big issue when you're dealing with cancer, the treatment of it, some of the stresses around having cancer, and exercise addresses some of those needs as well, and definitely proven.
Well, yeah, and I know that there's been some studies that have shown that actually participation, particularly in some of the Eastern practices, Qigong, yoga, mindfulness, meditation, patients who are actively undergoing treatment tolerate those treatments better. So there's just sort of a whole continuum there, I think, of prevention and then also wellness.
Actually needing less medications for pain, doing some of those mindfulness things can be really helpful.
So Dr. Ketchum, we have a couple of questions here about breast cancer. So we have a person from Duluth who'd like to know if she needs to start bisphosphonates after starting her aromatase inhibitor after breast cancer. So there's a lot in there to maybe explain to folks what those drugs might be, and clearly this is someone it's important for her to understand more.
So aromatase inhibitors unfortunately lower bone mineral density, and so that can be a problem for some people, and it really depends on what your bone mineral density is when you start, and generally we'll follow people's bone mineral densities while they're on the aromatase inhibitors to decide when at some point they may or may not need to start them.
And a bone density scan is something that's sort of like an X-ray, but it's not really radiation. It doesn't incur risk of greater problems, and so it's easily done in most cities.
Well, and I was thinking back to the conversation around the physical exercise and knowing that can actually help, maintain your bone density, so that should you have to be on a drug. And these aromatase inhibitors are typically drugs that patients will take at least for 5 years. And so, and since that impacts women who may already be at risk for bone density issues, it's important to...
And I think along those lines, I think that we're able to measure bone density, and that's part of the issue with osteoporosis, but I think the thing that we don't measure is weight bearing, and I think weight bearing exercise is very important. And I think that there's a fair amount of evidence that your fracture risk goes down quite a bit, and it doesn't have to be complicated. I mean, it can be as simple as a 20-minute walk every day, and I don't think it needs to be hard, but I think that's a very important thing for bone health and overall health.
So here's a question I think for all three of you to sort of weigh in on, which is, what is the recommended screening for breast cancer, mammogram, regular mammogram, digital if you will, versus the 3D mammogram? And I know I see that a lot in my office where I have patients that ask me that question, but I'd love to hear from the three of you. So Dr. Copeman.
I can start with that.
Yeah.
We order a lot of mammograms, and there's certain breast types that are really hard to diagnose cancers in. Ladies that may have a lot of fibroglandular density, sometimes cancers can be hidden in that. In our facility in Hibbing, we've pretty much swayed towards doing the 3D mammography for our patients, because that enables us to pick up things earlier, and in ladies who might have breast tissue that it's really hard to diagnose.
I think there's been a lot of media attention to what are really relatively small difference in recommendations on mammography. I mean, and I think what we need to understand is that they're very, very helpful in 50 to 70-year-old women, and that's the best. That's where they're the most useful. That's not to say they're not useful in other people too, but it's a combination of that's the group that's at the highest risk that we can have the most impact on, and the mammograms are a better screening test in that population because the breast is less dense. And that, I think, as you're saying, is part of the issue with 3D mammogram. especially for women with dense breasts, it's very helpful in that situation. It's probably not as important if you have normal density of breasts.
Right.
And so I think that the different societies have come up with different recommendations about whether it should be 45 or 50 and whether it should be every year or every other year. And I think that with the mammography that we do, it works very well. And I think getting it regularly is what you should do. Every 2 years is probably enough, although every 2 years tends to not happen. And so I think there's some sense in just doing it every year because it gets done.
Yeah. So.
I mean, I kind of agree with you there. I think there's been a lot of information out for people to try to figure out what should I be doing, because different societies have different recommendations. And I think kind of even along lines of the colon cancer, the best cancer screening is the one that you do.
Yeah,
You know?
fair enough.
Yes.
Yeah. Well, so we have another question. Klaus from Danbury would like to know, what's the screening process for testicular cancer?
That's a really good question.
It is.
Because testicular cancer is primary, the incidence is more in 15 to 30-year-olds. That's young people. And so the best screening test is the physical exam. And when we're doing our sports exams in young men, we always will check them for testicular cancer, but the most important thing is that they check themselves. Because if caught, it's very, very treatable. If not caught, it can be fatal. So we call it testicular self-exam, but also with the physician exam in that population.
So showing up for that physical exam, even in a younger person, is really important.
Yep.
Okay. So, Dr. Ketchum, I was really glad we got this question, and you'll like it too. What is CAR-T therapy? This is Robert from Buell, and this is an important therapy because it's sort of one of the really groundbreaking types of treatments. So,
I think CAR-T therapy is a very interesting new strategy to treat cancer. That's a whole new strategy that we've been doing more and more of, and it's basically immunotherapy. And I think that until relatively recently, the strategy to treat cancer was mostly to give something that damages cells, and you try to damage the cancer cells more than anything else, and that's what we do to treat cancer traditionally. But if you have a cancer, your immune system is supposed to keep you from getting a cancer, and it's supposed to get rid of the cells that are abnormal. That's an important part of your immune system. And so if you have a cancer, that system stopped working. And we have a variety of treatments that we do intravenously that address that, and CAR-T is a new strategy to do that, where you take the patient cells and you engineer them molecularly in a way that they identify and get rid of cancer cells. And that's an evolving technology. It's been very successful in a few kinds of cancers, and there's a lot of research going on in a lot of other kinds of cancers to work through getting that set up.
well, and it's almost as remarkable in some ways in terms of some of the responses that patients have had with that particular therapy, similar to what won the Nobel Prize, which are these what are called PD-1 inhibitors. It's a similar sort of like, not similar in terms of how it actually treats the cancer, but the idea that today, where we really for many years in some cancers really didn't have something new to offer patients, we now have things that really can be life-saving. So, well, so, but some of the treatments that we've had for a long time, and we know some of the risks of them, include something like radiation therapy. So we have a person from Superior who'd like to know, what are the long-term risks of radiation treatment, so 10 years out? So you want to start that one, and then I think it'll be interesting to hear from our family docs.
So, I mean, I think that there are risks with radiation. The caution, I would say, is that when people are telling people that they should be doing radiation, the benefits of doing it always exceed the risks, otherwise we wouldn't be doing it. But that being said, I mean, there's some damage to normal tissues whenever you do radiation. Probably and radiation techniques have gotten a lot better over the decades, but early on in treatments of some lymphomas, there were very high doses of radiations to the central chest, and that included breast tissue, and there was a lot of risk associated with that. The radiation that we're doing today tries very hard to avoid the breast tissue, but doesn't do it entirely. And so there are risks of developing what we call secondary cancers in areas that have been previously radiated. And then there's some scarring and some damage to normal tissues with radiation. And those can be addressed, but if the esophagus is in the radiation field, sometimes you can get esophageal strictures that need to be dilated. And there are some of those kind of problems.
Well, and I think you've just hit on something I think is important for patients to think about, so that, there's, as we say, there's no free ride when people get treated for things. And so the idea that there are side effects for the treatments, but you don't get the treatment unless you really need it. But with that said, sometimes it's not about a secondary cancer, it can be for other things. For example, fluid that might build up around the breast or the arm because there's been radiation, the strictures that can occur. But I also think a lot about things like cardiovascular health, lung health. And I'd just be curious if either of our family docs have any differences that they look for in their patients or screen any differently for risks if they know someone's had radiation.
The first thing that I always look at is that what part of the body do they have the radiation, and for what? Because radiation, as Dr. Ketchum had said, it works by killing cells, and radiation can't tell whether it's a cancer cell or whether it's a human cell, and so it will kill them both. Now, what technologies come now is that we're able to focus very precisely on the tumor itself, but we cannot exclude all the tissues around there. And so, for instance, if somebody's had, as Dr. Ketchum had said, something in the chest, we always look for esophageal problems. Something in the abdomen, you can have radiation, enterocolitis, which is chronic diarrhea. And so, first of all, we look at where it was. Secondly, we look for secondary tumors. And thirdly, any kind of long-term damage that may have been done for that, with that.
So we're going to be running out of time soon, and we've got, just as we knew, this would be a very exciting night because there's a lot of questions. And so I want to catch, there's several here, again, back to breast cancer, which is one of the most common cancers. A patient would like to know if breast cancer can recur after being 10 years of being cancer-free.
Yes.
Yep.
I wish I could tell you something different.
Right.
They're, especially the low-grade hormone receptor positive breast cancers have been known to show up even 20 or 25 years later. It's not very common, but it happens.
Indeed. So can men get breast cancer?
I think that's a good one to bring up because I think men don't realize that's an area that should be evaluated as part of a physical exam and be aware that breast tissue can be turn cancerous in men and women. The problem for men is because it's not thought of as on the high list, there's actually a higher risk of it being at a later stage when it is discovered, and it's more difficult to treat it, in that kind of stage. So lumps anywhere where lumps shouldn't be are worthy of going to your physician to take a look and see if that's something that needs to be dealt with.
Fair enough. And if breast cancer runs in someone's family, we have a person from Cloquet asking, how can you get genetic testing? What's the best place to start? I know what we do when we have a patient who's active.
I think in my opinion, that's a very important topic and one that I think people should be really aware of. We try pretty hard to screen our new cancer diagnoses for family risk, and there are available pretty straightforward molecular tests to see if you have a hereditary predisposition to cancer. I think probably the most important issue is if you know somebody in your family has been diagnosed with a pre-existing hereditary cancer diagnosis, if you have that report and you bring it to see your primary care physician or an oncologist, it's relatively straightforward to get genetic testing done on you to see if you have it, and you either do or you don't.
I'm going to just bring something up that I think is important. Is we're talking, it's good to remember that you have partners in your primary care person, partners with your oncologist, or will be able to develop relationships. So it's kind of a team approach, and finding the right testing for the right situation involves your history, your other health issues that you have, your own past history, and it could be really valuable to work as that team to decide what's the best for you, rather than kind of. You can do some things on the internet right now, and that's kind of a...
Yeah, you mentioned that earlier. You got to be a little careful.
Yeah, and what we do in our facility is that we have access to consults from genetic counselors. And so if our patients have some risk of certain types of cancers, we will actually set up an appointment with them where they do a very, very detailed review of the family history, looking at medical records, and then may recommend certain genetic testing for that.
Fair enough. Another question is, what are the early symptoms of throat cancer?
A persistent sore throat without any other associated infectious symptoms can be an issue. Swallowing issues that out of context for the situation. Others that you can think of?
We see neck masses.
Neck masses.
A lot of times patients will come in with a new lump. So.
Well, we're kind of out of time. So I want to thank our panelists, Dr. Jeffrey Copeman, Dr. Lloyd Ketchum, and Dr. Sandy Stover, and our medical student phone volunteers, Ryan Emanuelson, Tyler Floden, and Jennifer Tomala. Please join Dr. Mary Owen next week for our last program of the season on eye problems, when her panelists will be Dr. Charlie Ahrens, Dr. Matthew Kosick, and Dr. Lisa Graham. Thank you for watching. Good night.